Hello, everybody. I'm Dr. Jason Howe. I am an associate professor of gastroenterology at Baylor College of Medicine. I'd like to welcome you to the DDW virtual roundtable on MedPage Today. We're really fortunate to be joined by two panelists here today. Dr. Shirley Cohen-Mekelburg, she's assistant professor at the University of Michigan, as well as Dr. Jill Gaidos, who's an associate professor at Yale University. All right. The abstract I'd like to discuss or bring up for conversation was a very interesting abstract. It addresses a very common comment or question patients have for us about how long do I need to stay on therapy? How long, especially when referring to biologics. This was an abstract that was presented. It was a Danish study titled Discontinuation of infliximab therapy in patients with Crohn's disease and sustained complete clinical biochemical endoscopic remission, double-blind, placebo-controlled randomized RCT. So in this trial, this again was addressing an important question that we get a lot, is for patients who are doing well, who are in remission, and this was, I think, added the rigor of patients who are in endoscopic and radiographic biochemical remission, and randomized to continue on their infliximab versus go on placebo. How would these patients do? And in this study, they found about 50% of patients flared by the end of the trial. So what is your takeaway points or comments from the abstract from the study, and how do you incorporate that into what you tell your patients when they ask you this question?
I think, like you said, it's a very common question that we see in clinic. Patients want to know, do I have to be on this forever? At some point, will I be able to come off of this medicine and be on nothing? And I think with the STORY trial, we were under the impression that patients who were in endoscopic remission had a better chance, or at least a longer duration, where they may not relapse. But I think with this study, we now know that it's not protective. There really is still a very high chance of relapse when coming off of therapy. So it's nice to have a randomized study, a much more rigorous study, where we can say, we looked at this and, your chance is still 50% of relapsing in 1 year.
Yeah, one of the things I actually really like about this study is that, patients with IBD are a heterogeneous group of people. You have patients who have moderate disease, you have patients who have severe disease, you have patients who have fistulas, those who've undergone surgery. And so I actually really like that they stratified their randomization both by fistulizing disease and also by concomitant immunosuppressants. And so I think that was kind of a great thing to make sure they accounted for. I think, as you all are saying, the findings were not necessarily unexpected. I think what is interesting here, though, is that 50% of patients did do well after stopping their infliximab, and kind of the holy grail is if we can identify who those folks are. And so I think there really is a knowledge gap here that this study really is the beginning to that investigation. I think it's interesting, it is great that the patients who were included in this trial were those who were in endoscopic remission. I think it's interesting that they didn't necessarily speak to histologic remission, and that might be coming, let's say, in the actual manuscript. There's been a few studies out recently, including actually an abstract out of the University of Chicago during DDW this year that looked at ulcerative colitis, not Crohn's disease, but it was a small retrospective study, but they were able to show that, histologic remission was associated with the increased odds of relapse-free survival. That was not, only patients with infliximab. I think a majority of those patients were actually receiving mesalamines, but I think, one of the big things missing in this abstract is understanding people's histologic remission status.
Absolutely. And I think too, this study, when they broke out the patients who were on combination therapy, I think we had previously thought, well, maybe we'll do combination therapy, get them in their disease in remission, and then they may not need the biologic anymore, and we can just kind of maintain them with the immunomodulator. But it really, that group was relapsed almost as quickly as those who were just on placebo. So we now can see that that is not necessarily protective for these patients either.
How is, just to ask, what is your current practice when it comes to de-escalation, and how do you think this will change that, if at all?
I don't know, Jason, if you want to do that. Or...
I'll take it.
Okay.
But I kind of say, but the party line is that that if you're doing well on your biologic, my recommendation is that you stay on the biologic. I think before I would, making reference to the story study, as you already mentioned, Dr. Gaidos, I think this is even more supportive now, as it's a more rigorous, prospective, randomized, placebo-controlled trial, which interestingly shows a very, very similar number, that 50% chance they're going to be flaring, have a flare in the next year. I thought this study, which I think makes, is look for things that may interpret things with a grain of salt. They had 0% flares in their infliximab group at 1 year, which I wish I had 0% relapse of patients on therapy. So, there may be some things maybe there might be something else.
I'd like to see their drug levels. Maybe
they
keep them all at 50.
There may be some more details that we'll get out in the full manuscript. But again, my comment to my patients are that if you're doing well on it, we talked about adjustment, de-escalation in my mind for when I'm doing it and discussing with patients is if, for example, we had to escalate based on levels to get them into endoscopic remission, we'll talk about using drug levels and to de-escalate them potentially down to standard dosing. But unless they have an extenuating circumstance related to adverse event, cost, access, I try my best to discuss with patients the importance and recommendation of staying on their biologic.
Absolutely. And for me, the biggest concern too is I think patients have the mentality that they can stop these medicines and restart them. But I've had patients who did well on a thiopurine for many years, decided they want to stop it for a minor side effect, and then have a terrible flare where now we're, going through medicines to try and get them into remission. And so for me, that's the biggest concern is, we may not be able to use this medicine for you, and we may need to switch, to some other IV therapy or self-injectable that they hadn't been on before. And so really, they have to really decide if it's risk if they want to risk, discontinuing and maybe having to get back in the hospital because we can't get their disease under control again.
Jason, you did bring up a very good point about, the infliximab treated arm having 100%, remission at 1 year. And, I think to some degree, it does speak to the benefits of treat to target, right? Like if you are in endoscopic remission at baseline, you're more likely to stay there. But it also, while this is a randomized trial, it does make you wonder about the selection for the study. And, my guess would be that if you have a patient who's a little bit tenuous, you're probably not going to recommend them for a trial of de-escalation, or at least the possibility of being de-escalated. So that probably plays into that too.
Yeah, absolutely.
Yeah, those are great points from both of you. Again, just to summarize, this was a study, again, addressing a very common question that we get from our patients: can I stop my biologic? I think this study adds, again, another tier of data on top of what we've had before, saying if you stop your biologic, you have a fairly high, which I think most of us as clinicians and providers say 50% risk of relapse in a year is high. This is I think an interesting aspect of this study being randomized, a blinded placebo-controlled trial, is that we had that even patients who, as you mentioned, Dr. Cohen, were at the start already in clinical histologic or endoscopic remission. 50% of them flared in a year when they stopped infliximab. That to me is high. And the concern is, as Dr. Gaidos mentioned, that there is a percentage that I usually say about 10% that maybe won't respond or have immunogenicity or only partial response when they reintroduce the biologic. So that's definitely a concern. And I think it can be very helpful for us. It provides additional data for us to have this difficult conversation with our patients. And hopefully again, let them be aware of what the risks benefits are of continuation versus discontinuation of their biologic when they're in clinical and endoscopic remission. Thank you, Dr. Cohen. Thank you, Dr. Gaidos, for that great discussion. And thank you to the audience for joining us for this. And hopefully we'll see you for one of our other topics.